Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record, and also please remember to fill out the program evaluations, and please give us ideas in regards to future topics and future speakers. And as a testament to the fact that we actually look at those, this topic today was suggested by Dr. Thomas, who is a member of the audience. Today it's my pleasure to introduce Dr. Venkatesh Rudrapatna. Dr. Rudrapatna is a board-certified hematologist-oncologist. He's been a member of the staff here at MGMC and a member of the Hematology-Oncology Department of at McFarland since 2015. And he kindly has accepted our invitation today to update us on complications of cancer treatment. And please join me in welcoming Dr. Rudrapatna.
Good afternoon, everybody, and thank you all for coming, and thanks for the opportunity to talk. It was a rather broad topic, and so I thought I will fly over this in a 1-hour topic so that you can do a 3-hour fellowship in 1 hour. So, and if you have any questions, specific questions about certain drugs, we'll be happy to be around after the presentation, but I thought I'll sort of give you a whirlwind tour of where we are, where we're heading, and what we all are going to be expecting in the future, as well as far as the complications of these things. So I have no disclosures. So cancer treatments are broadly categorized into various buckets or bins. And in today's day and age, we can broadly divide them into medical treatments, radiation treatments, surgical specialty treatments, interventional radiology. So we have a lot of interventional procedures that are being done that are helping us manage our cancer patients. And as a result, we'll probably be seeing some of the side effects from that. And then the supportive care that goes along all of these other treatment modalities. I don't know if it's slow. So medical treatment is sort of how I explain to patients, actually, so that they can actually relate to what we're dealing with. Medical treatments are broadly divided into 4 big categories. This is what was used to be in the 1970s, 80s, and 90s, and early 2000s. That's what everybody's impression of what cancer treatments are, is you go to the hospital, you're sick all the time. That's what this is, the traditional chemotherapy. That's your F-16 bomber there. This is what started in the 90s, 2000, and has started changing how we're managing cancer patients, and that's targeted therapies. So you're a sniper, and you're using more specific guided treatments for patients. And in the last few years, this has changed a lot of cancer management, and as well as the side effects that you're all seeing in your various practices is the immunotherapy realm. So the way I relate that to patients is saying that's your FBI, your CIA of your body. And then ever so we have clinical trials, and fortunately, those numbers are increasing in many aspects, and that obviously is advancing medicine as well. Especially a lot of the immunotherapy trials are what's advancing today. So when I started fellowship, even in internal medicine training, when the oncology fellow would come in and blabber these long terms, bevacizumab and pembrolizumab, and it's like, what is he talking about? I have no clue what they're talking about. So I thought I'll give a little version of how do you break down all these fancy, big, long terms, so that when you go back to your respective practices and you see somebody from our practice or somebody with a drug name that's long and you have no clue what they are, at least you can break it up in pieces and understand what they are, and as a result, maybe also be able to predict what the side effects are. So, and it's not like some 5 executives in a boardroom are sitting and thinking, oh, let's pick up this name, and it's not like that. So the first thing that's important in understanding a chemo drug, or especially the newer drugs, is the last few letters of the word. It can be the IB or MAB. So anything that ends in an MAB is a monoclonal antibody. So it's an antibody that's used to treat treatment. Anything that ends with an IB is a small molecule drug. So, and we'll come to that a little bit later. So if you look at any drug that ends in an AB, you say, oh, that's a monoclonal antibody. So you can act as if you know everything. And if it ends in an IB, that's a small molecule drug. Then you go to the next part of that is a substem. And that tells us how did we, especially for the antibodies, how did we develop the drug? And that gives us an idea of the side effect profile. How could you react to these drugs? So if a drug ends in a XI, that means it's a chimeric and human and mouse protein. So there's a possibility that you will have a lot more side effects, because I tease with patients, you're getting mouse antibodies, mouse proteins, that's where your body is reacting. And partly that's true. And that's why people react a little bit to these drugs. So anything that ends in XIMA, for example, rituximab, which is a very common drug that's used in lymphoma, that's where it comes from, the XIMAB. Now you know that MAB means antibody, XI means chimeric antibody. Another example is Zumab. It's humanized mouse protein or antibodies, and there's bevacizumab. And again, that gives you an idea of how the nomenclature happens. If it's fully human, it's ipilimumab, M-U-M-A-B. So that gives you an idea. Then, 2 letters further this way, it tells you what's the target. Where is it working? So if it's CI, that means the vascular system. So bevacizumab. So the Zumab and then C, circulatory system. So then you can figure out, oh, it's working on the blood vessels, so maybe their side effects may be predictable. And you may be able to say, oh, maybe it's going to cause bleeding, maybe it's going to cause blood pressure issues. You can be able to figure that out yourself by just looking in the nomenclature. LIMAB. Again, Li means immune system based on the nomenclature. So anything that works on the immune system. We're seeing a lot of that on Super Bowl ads now. Keytruda and all those, pembrolizumab, for example. Again, the Lumab will direct, that's an immune system drug. And the T stands for tumor. We use rituximab here again. The Tumab suggests that it's a tumor-fighting antibody. So that gives you some flavor of how these drugs are designed. And the drugs that end with an IB, they have a slightly different nomenclature here. There are various categories, again, based on the mechanism of action. There's a tyrosine kinase, which anything with a TIB, like imatinib, which is a Gleevec medication, and the various other drugs that gives you the mechanistic actions of these drugs. And so when you go through a drug, you can sort of break it up a little bit, and that way you're not completely like, what in the earth are these drugs? And at least have some knowledgeable interpretation of what these drugs are. And then the first few characters obviously are the purview of the pharmaceutical company. They just pick those first 3 characters, and that's decided in the boardroom, I'm guessing. So what are the side effects of toxicities of treatments in health? So I don't like to use the word chemotherapy anymore, because chemotherapy in a way is old school, and chemotherapy, like I showed you, is usually the first bucket of medical treatments that are available. And today, I usually say it's medical treatments and not necessarily chemotherapy. Because if you tell chemotherapy to the patient, they're anxious, they're nervous, and they're bringing back memories of their grandparents and their parents sitting in the chair throwing up. And so that's sort of why I don't like to use the term chemotherapy. But there's a wide, varied aspects of side effects, as you can see, right from infusion reactions. We'll talk and touch base on a few of these. Nausea, vomiting, diarrhea, fever, mucositis, cytopenias, hair loss, and skin rash. And the long-term toxicity are included cardiac, so a lot of people from the heart failure team, fatigue, which is a big problem, we'll touch about, joint issues, memory issues, so there's this whole chemo brain cognitive issues, secondary cancers. Unfortunately, chemo and cancer treatments can cause cancer, unfortunately, as well. Issues with fertility, again, long-term skin issues, and neuropathy, again, can be sometimes the treatments are worse than the cancer we're trying to treat. And so we have to be really careful when we're using these agents. One other aspect so that you understand some of these things, so rather than saying, One oncologist says, oh, the skin rash was bad. Oh, the skin rash was really worse. So that's sort of a very subjective terminology as far as how do you relate a side effect to your peers or to a clinical trial or to your nurse. And that way the government, the Cancer Association, came up with this common toxicity criteria to objectively quantify what the side effects are. So if you go to the CTCAE website, there are side effects for each, for blood counts, for neuropathy, from heart failure to skin rash, and they're graded from grade 1 to 5. Grade 1 is mild, has very little limitation activity. Grade 2 is moderate. In fact, so whenever you're communicating, you say grade 2 neuropathy, then rather than saying, oh, he can't walk or he's dropping his object. So it's a little subjective. Skin rash was, probably bothersome or not bothersome. Is really, really subjective. So this is really helpful in communicating in a more coherent way with your peers, as well as anybody else picking up this patient can exactly know last cycle or last treatment, how bad was the neuropathy, how bad was the rash. And so we like to use, for most of the oncological patients, we like to use the common toxicity criteria. Just to give you a flavor of that, you're not intended to read all of this, just to give you an idea of neuropathy. And it sort of lists what do you mean by grade 1, grade 2, grade 3. So you can almost, I don't remember all of these by heart, so I always have to go look it up and say, oh, they are dropping things, so that's probably a grade 2, or they're falling and having repeated falls, that's probably a grade 3 because they're impairing their activities of daily living. So that's where these grades come in, and that's very helpful to objectively measure. So if you're ever curious about a rash or diarrhea or abdominal pain or blood count issues or liver abnormalities, you can look it up there. So this is old chemotherapy, and we all know that it impacted the cell cycle, it impacted the DNA, and that's how it influenced cancer. We're all aware of the cell cycle. It goes through various phases. And then, as you can see, we don't need to dwell into each mechanism of action, but each drug has its bucket on where it impacts the cell DNA and the cell growth. And there, as a result, results in cancer killing. And as a result, it causes side effects as well, because it's damaging DNA. And depending on where it's damaging the DNA, it's causing side effects. So this is just to give you a flavor of, this is what the cell cycle and the mechanism of the 1970s, 80s, and 90s were entirely focused on. And this is what we were dealing with. But today, obviously, with all these new agents, we're dealing with a lot of different other side effects. So important things is this infusion reaction. And this probably impacts a lot of you all. We occasionally send people to the hospital. We send people to the emergency room. They come to the ICU occasionally. And so as we went over the nomenclature, a lot of these are antibodies. They're produced from mouse or mouse and human combo. And so as a result, the body's immune system tends to react. And so these are really common with these antibodies, the rituximab, cetuximab, and various other antibodies. And so they can actually cause a lot of problems as far as blood pressure going up or down. Patients are febrile, they have chest pains, they get very anxious. So there are a lot of these possibilities. And a lot of these treatments, we try to give pre-medications with steroids and antihistaminics that really help control it. But despite these, a lot of these patients end up having some of these reactions, and either we have to stop the drug, slow it down, or completely stop it. And some people have really life-threatening allergic type reactions that we have to completely discontinue. And occasionally we end up admitting people to the hospital because of these side effects. So mucositis, everybody's probably used to seeing some of that, some of the toxicities in the mouth and the mucosal cavity. Typically the mucosa that lines the inside of the mouth, the gut, has actively dividing cells. So a lot of these cancer treatments tend to attack those areas because they have rapidly growing cells. Obviously, we can manage that with salt and soda water, pinch of salt, pinch of baking soda in water, and people can rinse. There's things called magic mouthwash, which is basically a cocktail of lidocaine, Maalox, and a few other ingredients that a lot of patients benefit from. And then, obviously, lidocaine viscous. And there's really bad, occasionally people require more intervention, IV antibiotics, hospitalization, IV fluids. And so these are in the more severe cases. So it's one of the true medical emergencies in oncology, neutropenia, or febrile neutropenia. So this is actually pulled out from 1971 in the New England Journal of Medicine. This is a report of 22 patients who showed up at a Baltimore hospital and with febrile neutropenia. As you can see, 11 of these 22 people died within 72 hours of the first positive blood cultures. That tells you the gravity and the importance of febrile neutropenia. It's basically a country with no army. And so that's what has changed the importance of this state. So what is febrile neutropenia? That's typically occurs about a week to 2 weeks. Some drugs are 3 weeks after a chemotherapy regimen. Usually you have to have a temperature greater than 100.4, at least for an hour. Or if you just had one temperature greater than 101, that labels you as being neutropenic and febrile. You have to have at least ANC of 1500. There's various grades. We can go back to the common toxicity criteria and look at the grades of neutropenia. But usually we start getting worried when the ANC is, which is absolute neutrophil count. That's you take the number of neutrophils and the number of bands, and that's a percentage of white count, and then multiply that, and that you get your absolute neutrophil count. And if you expect that to be less than 500, or it is 500 and less, that person comes into the hospital, no questions, no discussions, no arguments. So in oncology, obviously, there are people with high risk. Say if somebody's had a bone marrow transplant, somebody has had leukemia, and their counts have been sustainably low for a long time, or as opposed to somebody who has breast cancer and their blood counts are going to be down for 4 days. There's a big difference between the risks between these two. So obviously, the high-risk patients we're more anxious about because they've been sustainably low for a long time, as opposed to low risk. Low risk typically are the solid tumors, the oncology patients, and these are usually the hematology, leukemias, the lymphomas, the transplant patients. So this is the IDSA guidelines on how do we manage febrile neutropenia. Again, just to give you a flavor, you don't necessarily have to dwell in detail, but this is the kicker, and I've outlined that in future slides, that if they are high risk or not sure what risk they are, they go into this bucket. And they're low risk, or if you suspect their temperature is 100 and they had a solid tumor, then maybe you can manage them with some oral antibiotics at home with the caveat that they come in right away if there's any worsening of symptoms. So this, again, pulled out from the IDSA. The key take-home message, even if you don't get anything out of this talk, is how do you manage febrile neutropenia? That's what I want you to go out with, is managing febrile neutropenia. And you really want to use antibiotics that cover gram-negative, especially anti-pseudomonal. And so you can use cefepime, which we use a lot at Mary Greeley. Carbapenems, obviously, we try to reserve this for more sicker patients or more complicated patients, or Zosyn, that's piperacillin tazobactam. So these three drugs are the ones that we would prefer is initiated right off the bat who comes in. And starting and the time frame of this is very critical. If they come into the ER, they should get the blood cultures drawn, a chest X-ray, UA, and bang, they get their first dose antibiotics. That could be the difference between those 11 cases in 1971 as opposed to today. Vancomycin, or the things that cover gram-positive, you don't necessarily need to start on everybody unless they're critically or hypotensive or septic. You can sort of reserve this to the future if they're still not responding to the gram-negative coverage. And then these things, especially if they have an obvious abscess or skin infection, then you certainly want to start them on IV vancomycin. As far as antifungal, these usually start getting to be relevant if they have a more prolonged duration of neutropenia. Again, more so in the hematological malignancies that you really want to start thinking of antifungal. And we're very fortunate that we have two great infectious disease doctors on staff here, so we always rely on their expertise. But a lot of hospitals, a lot of institutions, unfortunately, don't have the expertise of infectious disease doctors. And so that's where knowledge of the complications of these treatments are very, very important. And then occasionally these people require preventative treatments for antifungal, especially when there's risk for prolonged neutropenia. Then we'll switch to nausea, which is sort of the biggest fear for most patients who are undergoing chemotherapy. So just giving you a high-level overview of the mechanism of nausea. And there are proposed many mechanisms, but the main center is the medulla oblongata. Well, that's where the nausea center, the vomiting center is. There are higher cortical centers that feed into this. There's your middle ear and everything else that feed into that. Your GI systems feeds into that, sends messages. And there's a chemotherapy trigger zone that's also quite important that we're starting to target agents into controlling nausea. That gives you sort of an idea of mechanistically what are the areas that are causing nausea. Then you can accordingly go and target these areas with drugs to control the patient's nausea. So this table, obviously, it's for your reference. We'll touch a few topics and a few points here, but you can use this as a reference going forward. It's actually very helpful. It gives you the mechanism of action and examples. So, for example, scopolamine, it works in the muscarinic receptors, usually used for motion sickness. Somebody's going to go on a cruise, you could put them on a scopolamine patch. Somebody's getting chemo, every time they move their head and they get nausea, you can put them on a scopolamine patch. But be aware of the side effects of these agents associated with it. Obviously, these are associated with drowsiness and dry mouth. Benadryl, for example, can also help with motion sickness, and as everywhere is, it can cause sedation and sleepiness. Prochlorperazine or capazine, that's typically used as a common side effect, as a common agent for nausea. The main thing is extrapyramidal side effects. So you'll occasionally see patients, and we end up sending people to neurology because they're having tremors. And then when you look at the medication list, if they're taking a lot of compazine or prochlorperazine, that's the side effect, and that's what causes that side effect. Haldol, usually used for, especially in the hospital, for patients who are delirious, but it's actually a good medication for postoperative nausea and some of the cancer patients who are really struggling. Reglan or metoclopramide is, again, a great drug for motility. So people who have GI motility issues, gastric, diabetic motility, it's used there as well. Again, keep in mind the side effects of those. This drug, this class, the 5-HT3 blockers, are one of the mainstay for oncology and really has changed the side effect profile for a lot of the chemo drugs. And the Zofran or ondansetron and palbociclib, which is Aloxi, these are really great anti-nausea meds and are part and parcel of a lot of the regimens that are there today. Olanzapine was not used a lot, and a lot of the guidelines have changed, now are including olanzapine, which is Zyprexa, into the regimen of chemotherapy. And so we're actually starting to use this a lot more in managing sort of resistant nausea. This is, again, is a very strong antiemetic, the epirepetant or Emend, and is great for people who really need delayed nausea effects and very, very strong nausea. Steroids is a great nausea medication, but really nobody knows how it works. Maybe Dr. Carreno may know. Benzos, lorazepam, which is Ativan, is great for anxiety, anticipation, nausea. And then the big hot topic of today is obviously the cannabinoids, which obviously there are pharmaceutical agents, and then there's also the Colorado version as well. So how do we figure out which one to give and what to give for all these patients? So thankfully, the pharmaceutical industry has come up with what is the potential for these agents to cause nausea, and they're usually chemotherapies are blocked or put into various buckets or bins. There's Hymetic, and for those things, you really need to use the epirepatents and the Zofran-like medications, plus steroids, plus olanzapine. So you have to basically throw every agent onto them to help the nausea. Some that are moderately risk, you don't have to use a lot of agents. You can use the ondansetron and steroids, and that some that are really low risk maybe get away with just some compazine, which is prochlorperazine, or some steroids. And so that's how we figure out what to give patients, is based on their emetogenic potential of these drugs. Diarrhea. So diarrhea is obviously, again, a complication we see often in patients. Risk factors are obviously if they're elderly and they've had prior surgeries, they're on antibiotics. And Dr. Arbulu and Dr. Fulton have probably given a lot of talks about C. diff. So obviously, you've got to first make sure it's not C. diff before we start treating and assuming it's just the chemotherapy that's causing that. And so obviously, hydration, hydration, hydration. It's important to keep them hydrated. and the Bart diet, that's grandma's recipe, and then Imodium, loperamide, and Lamodal. There are 2 drugs that we use a lot. Rarely, people who are very resistant, we end up having to give them octreotide, which is a subcutaneous shot in the hospital. And rarely we have to use this in the clinic. So these are for really resistant cases of diarrhea. Hair loss certainly is an important topic for a lot of patients. Recently, FDA approved the cooling cap devices, especially the automated circulating cool caps. The data is about mixed. Based on the studies, about 50 to 60% patients will keep their hair in about 50% of the time. And so there are also these standalone cool caps that you can put on the head, but you have to keep changing them. You put them in the freezer, take them out. Big issue is they're not covered by insurance, and they're very expensive. It's almost $2,000 per treatment. So they're pretty expensive. And so most patients are not able to afford these things, and I'm hoping that as technology improves, these things will come down, and I'm hoping that we'll probably get away from a lot of the drugs that cause this with the way medicine is advancing. Cardiac toxicity. There's a whole spectrum of things we can cause with chemotherapy. Most people know about the pump function abnormalities. That's the Anthracyclines, which is your drugs that we normally use in breast cancer and leukemias that can cause pump function abnormalities. But keep in mind, we can cause a lot of arrhythmias. We can cause hypertension, especially drugs that we saw, the Cizumab. The C stands for blood vessels, Avastin blood vessels. Those things can cause hypertension. Blood clots are very common, or not very common, but are common things that are noted with some drugs that increase your risk for thrombosis, in addition to cancer itself being a prothrombotic, and ischemia. There are certain drugs, 5-FU, capecitabine, for example, can induce ischemia in patients. The gold standard, obviously, is the anthracycline. There's some lifetime dose limit. The mechanism is not clearly known, but there's hypothesis of it being mediated through iron-free radical. And so there have been some studies looking at using iron chelating agents for patients who need continued doses of anthracyclines. And obviously, there are other risk factors that magnify the side effect. Fatigue is obviously a big, big issue. And unfortunately, there are not great drugs for this because the cancer is causing the fatigue, chemotherapy is causing fatigue, and the side effects are causing fatigue, the low blood counts are causing fatigue. So there's a multifactorial reason for fatigue. Ginseng was actually showing some data. Just recently in ASCO, which is the American Society of Clinical Oncology, there was a recent publication showing the Korean ginseng has shown to have some statistically meaningful improvement in benefit. The Mayo team has done a study from the Wisconsin ginseng. So there's a Wisconsin cooperative group that makes ginseng. And so I went to a meeting and talked to one of the investigators, and they said, you really have to go get it from the folks from Wisconsin. You can't just get any ginseng if you really want to believe their data. And it's been shown, and it's pretty well handled. So I've started using this on some of my patients. Ritalin, or methylphenidate, is also a drug that we use. And in some studies, it has shown to have some improvement. This ginseng study actually compared some patients that had the Ritalin on, and they actually found it to be superior to Ritalin in some patients. So there's some benefit of that. And then there's other non-medicinal approaches, Tai Chi, yoga, acupuncture, things of that have been shown in small studies to be beneficial. Then stepping outside of the realm of the traditional chemotherapy, we're stepping into the sniper world, the targeted therapies. So again, not to necessarily bore you with the mechanism of each targeted agent, but just to give you an idea, this is the cell surface right there. These are the tyrosine kinase receptor and intracellular components. And it's like a relay circuit. So we think very smart and we try to block one, but then the body has a lot of other switchback mechanisms to. And so there are all these receptors within the intracellular domain, some are extracellular, that are being blocked by drugs, and then as a result are treating cancer. But these are all the side effects because of blocking those drugs. or those receptors. So VEGF is the vascular endothelial growth factor. Those are the drugs such as bevacizumab, which is a vascular growth factor, which is Avastin, that's used in GBMs, which is brain tumors. It's used in lung cancers, in colon cancers. As we said before in the first slide, because it's affecting the blood vessels, you can predict, oh yeah, because it's affecting the blood vessel, guess what? It's going to cause hypertension, because it's going to impair the circulation in the glomeruli. It may cause proteinuria. And it's very important for the surgeon in the room, obviously. They really will spank ours and tell us to keep them away from Avastin at least 4 to 6 weeks before surgery and 4 to 6 weeks after surgery, because that can certainly impair wound healing. And then there's a long list of other side effects. Some of the other EGFR, which is endothelial growth factor receptor, erlotinib or Tarceva, which is a drug that's approved for lung cancer. The common thing is acneiform skin rash and diarrhea. And some patients of mine will swear that they'd rather deal with the cancer than the drug, because it's quite disabling. Sometimes the rash and sometimes the diarrhea. Again, understanding the mechanism sometimes helps you to predict what the side effects are, rather than just sort of trying to memorize what the side effects are. These are the drugs that work on the leukemia gene, the BCR-ABL, which is the Philadelphia chromosome for CML. Again, they can cause a wide range, especially things that affect the heart, rhythm functions, blood count issues. And then the HER2, which is a receptor that's used commonly in breast cancer, now in GI cancers, it again can impact the systolic pump function. So especially when you combine two drugs, you got to be really careful. You're impacting the heart function. And then there's ALK inhibitors, which are again used in lung cancers. As you can see, the theme is diarrhea, diarrhea, diarrhea. So if any drug ends in an IB and somebody asks you what's the side effect, diarrhea and skin rash, you won't be wrong. So again, think of it. You see a drug there and say, why do you think this person's having diarrhea? You say, oh, maybe it's the drug. So that's a way to think of it, cross-referencing the nomenclature of the drug. And the JAK2 inhibitors are, again, for certain types of hematological malignancies. Understandably, can cause some cytopenias. But just to give you a flavor for not necessarily understanding each mechanism directly, but just a flavor of how the drugs work, and as a result, how the bystanding effects of these drugs are. Just to give you an example, this is Sweet 16 again. For this gentleman in the 70s, he's got acneiform rash again from erlotinib, which is Tarceva for lung cancer. And these people require treatments as if you would treat acne. So basically using metronidazole gels, oral antibiotics like doxycycline, Flagyl, and the same thing you would use for acne in a 16-year-old. So then the next step of the FBI, which is the current generation of treatments, and we're going to be seeing a lot of, and you all will be seeing a lot of the side effects and the complications that, truly speaking, most of us don't know what they're doing and what they're going to cause. And so you might be surprised in your various practices, from cardiology to neurology to endocrinology to general medicine to ER, you'll be seeing a lot of these potential toxicities of this. And so I'll probably take in the next little bit to talk about immunotherapy, and especially there's a lot of stuff in the media as well. Immunotherapy is basically using the body's immune system to fight cancer, and there's a whole spectrum of new drugs or pathways that are being looked at. There's the viral vectors, which we had talks, I think a month or two ago. One of the professors from Iowa State was looking at some of the vaccines, using that for treating cancers and treating infections. Adoptive B-cell therapies, which obviously we've seen recently in the news about approvals of drugs for pediatric leukemias, the gene therapy, which is CAR T-cell therapy, there's dendritic therapy. So there's just to give you a flavor of all these things, and these are all, a lot of them are trial phases, a lot of them are approved, a lot of them are getting approved. A flavor of the agents, and that list is probably growing every day. So if I go to sleep for a week and wake up, there'll be 4 more drugs and 4 more indications for immunotherapy there. It started off with melanoma, then we got lung cancer, then we got lymphoma, then we got kidney cancer, then we got bladder cancer, Hodgkin's lymphoma, and then we got other broad categories of indications. So just to give you an idea of what drugs are we're seeing now. And this list is going to keep growing. And you all, as a team, we're going to start seeing some of the side effects and toxicities, because I would predict that in the next 10, 15 years, very few of the patients will be on our conventional chemotherapy. A lot of these will be the new treatments that patients will be on. Just to give you an idea of the mechanism of some of the newer agents that you see on TV, the Keytruda and Opdivo that you've heard about, which is pembrolizumab and nivolumab. And the research, some of that was based on cancer fatigue. That means the tumor cells are expressing certain receptors called PD-L1 receptors that in turn binds to receptors on immune-activated T cells and disables them. So they go to sleep. The FBI says, oh, he's my buddy, I'm just going to be there with you. And so what researchers found is this ligand binding to the receptors are making cancers not recognizable by the immune system. And as a result, they said, what if we block this ligand or these receptors, and as a result, then activate these T cells? And that's what these drugs do, is they are blocking these. There are things that block the PD-L1, and there are drugs that block the PD-1, and as a result, activate the immune system, activate your FBI, and as a result, then having the immune cells go and recognize the cancer and treat the cancer. Similarly, slightly different receptors, which is a different drug, which is ipilimumab or Yervoy, which is the CTLA-4 pathway. Again, sort of the concept is similar. You're trying these receptors and ligands are making the immune cells not as responsive, and you block them, and as a result, achieve response. Just to give you a little 2-minute spiel on the latest hot off the press drug, which is the CAR T-cell therapy that got approved for acute lymphoblastic leukemia for pediatric patients. What they do with that is, basically they take the T cells, they take it offline, they genetically engineer it. They introduce a vector, either a viral vector or another protein into it to alter the gene so that it expresses and recognizes antigen that are present on the cancer cells. Then they create an army of that. They multiply that offline, and then they provide immune-altering or immune-suppressing treatments to the patient to calm the immune system down a little bit, and then they give this army of these recruited T cells into the patients. And then they, as a result, say, oh, there are these bad guys, bang, 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 bang. And that's the hypothesis of these new genetically engineered T cells. And that's the next big foray of the treatment that we're going to be seeing. It's approved for ALL, we'll probably get approved for lymphomas, probably get approved for multiple myeloma, and then they're starting to look at solid tumors. But we're going to be causing a lot of problems. We're going to cause a lot of havoc with the immune system by altering this. And those are the side effects they're experiencing in these trials. So, what does it cause as a result? We think we're all that smart, and the body is saying, okay, I'll show you. And as a result, these are all the potential side effects. Pretty much any and every organ can be impacted with immunotherapy because the immune system is everywhere. And so you can have eyes to the pulmonary system, to cardiovascular, to the gut, to vessels, to blood, to skin, to kidneys, to pretty much everything. So there is data showing side effects for all these organs. Just to give you a flavor of the time course, and obviously you can see that these can happen at any time, some of these toxicities. Not like chemotherapy, you give them, they get nausea tomorrow. No. You give the drug today, and you may get skin toxicity after 4 cycles. It's a little bit hard to predict when these side effects might occur. And again, just another graph of one other drug, just to give you an idea of the time course of when these side effects may be. And as you can see, this is a plateau. This can occur at any time, even after stopping the drug. So it's a little bit hard to predict some of these side effects of these agents. Some snapshots of some lung toxicity. That looks like pneumonia. And obviously, sometimes we are forced to treat it like pneumonia first. And then we end up figuring out, oh, it's not really pneumonia because they're not getting better, and that's still the way it is a month later. And that's immune toxicity to lung, because all that tumor, the immune T lymphocytes are crowding and causing a lot of cytokine storm in these areas, and that's the problem, these toxicities. So I just want to give you a few cases of patients I've had have had toxicity with these drugs. This is a 60-year-old female patient of mine who had metastatic melanoma. She was started on a drug called ipilimumab, which is Yervoy, which works on the CTLA-4 antibody. She got 3 cycles, and then she showed up into my clinic, brought in by the family, somnolent, not talking. She was falling. We drew labs. Her sodium, as we can see, is way down there. Potassium is non-existent. Cortisol is really not there. And TSH was through the roof. She had pan-hypopituitarism, basically the immune destruction of the pituitary gland from this drug. So we had to put her on steroids and thyroid hormone, and we get endocrinologists on board. Second example, 55-year-old with stage 3 melanoma got the same drug, adjuvant ipilimumab. 2 cycles later, he started developing diarrhea. And this is not like going once or twice. He was sitting in the toilet for the whole day. And the treatment was steroids for a lot of these things. These are stimulating the immune system, so you calm the immune system by steroids. We gave him steroids, and he got better for a day or 2. Bang, it came back again. So we tried this exercise for almost a month. He was in the hospital waxing and waning steroid doses, and he didn't get better. Unfortunately, and eventually then we had to use infliximab, which is Remicade, which is a drug we use for Crohn's and ulcerative colitis. And that alters the immune system and calming the immune system in ways that these drugs were tweaking the immune system, and that eventually took care of the problem. So giving you a sense of, we don't know what's going on in the immune system in ways that may be very deceiving, may be very, very different than what we've all seen so far, which are traditional chemotherapy, nausea 2 days later. No, that's not what we're going to be seeing for a lot of these patients that you will all be taking care of in the future. 64-year-old with lung cancer on nivolumab, which is Opdivo. He was on this for a long time until he did well. One day he came into my clinic for his treatment, and his creatinine was 2.5. He normally runs at 0.6. So we did the whole workup, got the nephrologist on board, did all the workup. Nothing was revealing. And then eventually we had to blame the culprit to be nivolumab, an immune-mediated kidney injury. Again, not necessarily you have to read this, but the European Society of Medical Oncology have come up with guidelines on how to manage them. And all these guidelines, for the most part, include steroids. So that's the main thing. Again, take-home message, a lot of these treatments, the toxicities of the ipilimumabs, the nivolumabs, the Keytrudas, all these drugs, the main treatment for these are steroids. Again, please touch base with your oncologist before you give them steroids, because sometimes it negates the effect of the treatments you're giving. So keep that in mind before you pull the trigger in giving steroids. Again, just a flavor of managing the colon toxicity of that. And then we'll just briefly touch base on, we may not see a lot of these patients, but we do see some people coming back from Iowa City and Mayo Clinic who had a bone marrow transplant. And the bone marrow transplant is when they get a new sheriff, the new immune system from the donor. And as a result, the new immune system is fighting with the native immune system. So people have graft versus host disease. So acutely, which typically we won't see because they're still in the hospital at Mayo or Iowa City or Kansas, they develop a lot of toxicities, skin rashes, colon toxicities. This we may see in your primary care practice, in the ER, in oncology practices. This is chronic, so the patient is 2 years out from transplant and they're establishing back with primary care. You may be watchful for some of the chronic toxicities, some skin scleroderma type thickening, arthritic type deformations in the joint, the skin rashes, hair changes. There's a lot of things that are possible in patients in the longer term period from chronic graft versus host disease. So just being aware that if somebody's at a transplant, a bone marrow transplant, an allo transplant from a donor, not their own stem cells, but some from a donor, keep these in the back of your mind if you see them in primary care or urgent care, even a year, 2 years, 3 years, 5 years later, there's always a possibility of having some chronic graft versus host disease. And briefly, not my area of expertise, but I thought I'll touch base, given it's part of oncological treatment, is radiation. And as you can see, these are patients who have throat cancer, squamous cell cancer of the oropharynx, and they're getting radiation and chemo. And imagine, this is the outside. Just imagine what's on the inside. So these are the patients who are struggling to eat and swallow, and we have our surgeons help us put in feeding tubes and ports and try to keep them going through all of this sort of suffering from radiation toxicity. So that's mucositis, skin toxicity, dry mouth, occasionally cause headaches, especially if you get whole brain radiation, lung inflammation, lymphedema, for especially for breast cancer patients getting radiation after breast surgeries. Late side effects, radionecrosis, secondary cancer. This is an example of angiosarcoma of the breast in a patient who has had breast radiation after a lumpectomy. So keep in mind this can occur late, but those are potential side effects. Cataracts, cognitive changes, especially people who get brain radiation, hormone gland abnormalities, especially if they get radiation to the back of the throat for throat cancer. You're right, the thyroid gland is right there, so you might have endocrine abnormalities and hearing loss. Okay, and I think I can't leave this alone, so I had to bring this up. And I think that's a big, and we have bills being proposed in the Senate and every few days. And so I think we got to really touch base on the financial toxicity of all of this. Some data and some statistics, so it's very sobering. You know, a lot of us are fortunate where we are, but there are a lot of patients who are not only dealing with their cancers, but they're dealing with the financial toxicities. Some studies have reported $1,000 out-of-pocket spending on an average for a patient. That's a lot for most common people. 18% or so paid more than $2,000 to $5,000 in out-of-pocket expenses. So that's a lot of money. Are people missing work? For sure. How does that impact? They're not getting their paycheck. So there are some studies that showed that almost 25 days of missed work on an average per cycle of treatment per year. Their ability to do the jobs they were able to do are compromised, and as a result, they're losing their jobs, they're losing their livelihood, and on top of that, they have these expensive drugs to pay for. So that's a very important aspect of all of this that we shouldn't forget. An average of $27,000 in debt was an average statistic. So that's a lot of financial stress that we have to deal with. Twice the risk of filing for bankruptcy. That's a big deal. And obviously there's a lot of other studies showing similar statistics on the financial implications of cancer treatments. And not to say the least, don't forget the caregiver, the family. And we're treating the patient with chemotherapy, but the family is equally suffering in a lot of different ways from the side effects of cancer and the treatments. The pressures, the financial pressures, guilt. I see this all the time. The spouses are really, they're emotional, they're guilty that they're not there enough to help the patients or their partners. There are constant demands. The wife will be up all night because he's in the toilet every 10 minutes or he's throwing up every hour. And that person has to go to work next day. That's a lot of stress from the caregiver. Changing roles from being the mother to mother and father, and to be the stay-at-home mom, to be the breadwinner. Those are a lot of changing roles. Lack of time for self. It's a full-time job for taking care of some of the cancer patients. So that's a big deal. And a lot of the nurses probably have a little bit better in-depth understanding of this because they probably spend a lot more time from a social perspective with the patients and their family. And anxiety and depression is probably also an important aspect that we shouldn't be forgetting, not only for the patient, but also for the caregivers. So it does take a village to take care of all cancer patients, and this village is here, the family, the society, the government, and I appreciate all your input and help with taking care of our cancer patients. I'd be happy to take any questions. Thank you. Yeah. Right. Yeah, so that's obviously it's a broad topic. So depression screening is very, very varied at the minute you convey to somebody that you have stage 4 XYZ cancer, sure, they're going to be depressed at that minute of time. So it's a little bit of a, you don't want to necessarily over-treat people at the same time. Keep in mind, if you saw that chemo side effect, the nausea side effect profile, a lot of the antidepressants have side effects by themselves too. So I think there is a flavor of anxiety, and there's a flavor of depression, and there's a flavor of toxicities from these drugs and the chemotherapy. So I think, yes, it's under-recognized and undertreated for a lot of our patients, but at the same time, especially men, it's harder to convince them to get on an antidepressant as it is to female cancer patients. So yes, there are some patients who would certainly benefit from either they're reluctant to, or we're probably not doing as great a job to address their mental and cognitive issues. So I think that's a good question. We don't have anything specifically at this point in time, no. Not to say that.
Have we changed how our model for how we treat that in terms of maybe cetuximab versus cisplatin?
Right, so as of now, the data does not suggest, there's no head-to-head comparison for HPV positive patients, so it's given case-by-case basis. So if it's a patient that you would suspect would not be able to handle cisplatin, then for sure we would be giving them cetuximab. It'd be age or comorbidities. But the data still supports 100 milligram per meter square of cisplatin is superior as first treatment. So, but yes, the move is more towards using cetuximab for that patient population for people who are not able to do, unless we get large randomized studies comparing head to head, because the cetuximab was compared to radiation alone and not to cisplatin as a comparative arm. So we don't have that data to provide us that right information. But yes, do we use cetuximab? Yes, certainly for a lot of these patients who are HPV positive. And that certainly makes a difference in the outcome as well.
So is it worth, though, testing patients for the HPV?
Yeah, we send HPV for all our head and neck patients. Squamous for head and neck, yes. That's by default, our pathologists will request them to run that. Because not only it's a matter of treatment, but it matters in outcomes. Sure. Their prognosis is significantly different based on data suggesting that their outcomes are far superior to people who are HPV negative. So yes, we run that for every head and neck squam. Thank you. Okay, I think we're overwhelmed by cancer. Thank you.